So let's briefly touch now on cervical trials. This is a different beast, right? So in theory, it's the same concept, but there are some special things about the cervical spine that we have to take into consideration.
Yes, of course. I think the cervical spine for me has always been more fascinating, and I think it is more of a mystery for a lot of even experienced implanters that have a lot of experience in the lumbar and thoracic area and really have hesitation to sort of move into that cervical. If you have an opportunity during your training and fellowship time to get in on cases with cervical placement, I think it's very, very important, because you'll start to realize that there is a level of comfort that you can obtain at that cervical level, as long as you're paying attention to a few details. One is you're not going to get that wonderfully flat, shallow entry angle. The cervical spine and its anatomy just doesn't afford that. Spinous processes come straight up at you, and you've got a more direct approach, so you're going to have a steeper entry angle in order to get into the epidural space. Be careful, because that also means, as we discussed before, you don't have the advantage of the reduction in potential wet tap and all that, so you've got to be very careful. My recommendation as you start to do these is that you really place the needle and continue to use your lateral views or a contralateral oblique view to get a gauge for where that needle is as you're doing your loss of resistance, so that you take your time getting into the epidural space. Once you're there, the lead typically travels in the dorsal epidural space, because the contents of that canal is thicker, being that the cord is present and the canal diameter space is smaller than it is in the thoracic area, so you don't have a whole lot of room to move around in there. And when you roll anterior or irritate roots, nerve roots, as you steer, the patient will immediately tell you, and you'll know. So there are some barriers, safety barriers that are in place that actually help you guide the lead more safely in the cervical spine. So I think with the cervical spine, preoperative image evaluation is so important as well. And I'm a big fan of reading your own images. I mean, there's no question about it. That's one of the safest ways to make sure that you don't harm a patient. But what I look for is not so much just canal diameter, but I look for CSF thickness. What do I mean by that? So when I look at the CSF, I want to see circumferential CSF around the cord, such that if I have a couple of millimeters of CSF around the cord, I know that when I place my lead and it puts a little pressure in the epidural space and displaces CSF, that it's not going to displace it to the point where it applies compression to the cord itself.
This is so important. I just want to emphasize this. You know, I tell my residents and fellows, absolutely look at the images. You know, not only look at the images, please screenshot these images, put them in the notes, you know, at multiple levels. Screenshot them, you know, lay them side by side, your axial and your sagittal images, use your cut lines, figure out what's going on, and put it in the chart. So you don't have to, every time you want to look at this patient's chart, you don't have to actually open the MRI and do this again. You have your screenshots and you just put them right there in the note. And right before you go in the OR, you can open up your note and look at those images again. And it helps you make a decision. It helps you make that very difficult decision sometimes. Or are you going to use percutaneous leads, or are you going to refer for a paddle?
Sure. Or are you going to use 2 percutaneous leads versus 1 percutaneous lead?
Yeah, can you comment on that?
So in those situations, you really want to see, is this a bilateral concern or a unilateral concern? Clearly, in a unilateral situation, mostly 99% of the time, I'll place one single lead. I'll err a little bit to the side where they're having the problem, and I'm almost guaranteed to get good coverage over that side. If somebody has bilateral symptoms, what I'll do for the trial is I'll attempt to do enter maybe a little to the left and then have the lead tip a little to the right, and have the programming such that I walk up and down the lead and I find the sweet spot in the middle, and that actually gives me where the anatomic midpoint is as well. And if that does really well, I'll do the perm the same way. But if I'm just having a difficult time getting one side maybe less stimulated and the other side heavily stimulated, in those situations I might look at placing 2 leads, but if I do, there's got to be plenty of CSF thickness, the circumferential CSF around the cord, in order for us to move in that direction.
Yeah, so when you're looking at the cervical spine, it's really important to be looking at the amount of space, because
Yes.
it helps you determine if you can place percutaneous leads, and if so, can you place one or two, or do you just send this one out right away to help
Right.
avoid complications, which can be really quite devastating, right?
Yes,
if you make
yes.
the wrong decision there.
Of course.
What about, where do you enter? So we're not really going to be able to enter two pedicles below, which you mentioned that you're going to have this steep trajectory, but where are you actually entering? So some people, I've heard people say, yeah, I enter, usually T2, T3, maybe T4, T5. Other people are actually entering, T12, L1 and just steering the lead all the way up. So let's talk about some different approaches that people take.
Sure. So my approach is T1 to T4. I find the best space that I can in terms of entry point, and advance the lead, and as we discussed, maybe approximately one pedicle level below. So instead of the two, it might be one. It might even be a half of a pedicle below, in order to get into that space. My comments on doing a T12L1 entry and driving it all the way up into the cervical spine, as a trial, I'm indifferent to that whole concept. But as a permanent implant, I would be concerned about the potential for lead fracture. And the reason I say is the longer that lead travels throughout the canal, the more likely that you're going to have problems, because you're flexing and extending at multiple different levels. So you enter T12L1, you've got the lumbar flexion and extension, and you have your cervical flexion and extension. And the potential for damage to the lead is certainly greater in that situation. Although there are people that routinely do it, I personally refrain from doing a permanent implant in that technique.
Hi, Minnie D here. I decided to ask Dr. Sean Lee for his take on anatomical variables and angle of entry.
Here I'm going to just illustrate the differences in angle of the needle. For a thoracic approach, a paramedian approach, you want to ensure that there's a shallow needle entry. I would suggest approximately a 30-degree needle angle. Conversely, in a cervical approach, you see that this angle is a lot steeper. This has to do with the angulation of the cervical lamina. I like to recommend the use of a curved needle. This curve allows additional maneuvering, allowing the provider to walk essentially over the superior edge of the inferior lamina. This curve also gives you the benefit of steerability, so you can come in a little bit more medial or lateral. I touch my needle tip onto the periosteum. This allows me to keep track of where I am and safe. I would gently walk off the lamina, feel for this little ridge, and then enter the epidural space as I get my loss of resistance.
Thanks, Dr. Lee. Let's head back to the studio.
So that's a really good introduction to a cervical spine. And we do keep talking about, it's different anatomically. There's a lot of rotation, you're not talking about anymore this and this. You've got like this whole plane of these multiple planes of rotation, right? So we have to think about the potential for migration may be higher. Some people do place the patient in a cervical soft collar. Do you think there's any advantage to this in practice?
Yeah, I think like with all patients, I mean, we're so focused on making sure there isn't migration and wanting the patient, and we give them the instructions and we do all that. But if you're a patient in chronic pain and I just put this cervical stim in and your pain's gone, the last thing you're thinking about is whether I'm moving my neck or not. So I tell patients all the time, I said, I don't care, I want you to wear this cervical collar. I don't care how good you feel, I don't care how safe you are and not moving your neck, wear it. Because it gives them a mental reminder that something was done and that they should be careful with it. I think if you can get a few weeks of the cervical collar in place, the likelihood that you have migration beyond that starts to diminish significantly.
So now we've talked through a cervical implant, the things that we want to be careful about. Let's go to the lab and show everyone how it's done.
Great.
All right, welcome back. So we've now covered lumbar placement, we've figured out how to tunnel this device and place the pulse generator. What about cervical placement? How about we learn about that?
I think that's a great idea. I think a lot of times people get very intimidated by cervical placement, and I think that the more we understand about the anatomy of the cervical spine and the more we practice performing this procedure, you start to realize it's not quite as scary as we imagine. A couple things to keep in mind. Right here what I have is a needle aligned with my fluoro image showing me that I have this midline placement so I can identify where my midline is. Then I'm going to look at the interspace that I'd be interested in. I'll get a picture there. And let's say we've chosen this interspace and that's where we're going to enter. What we want to do is for the cervical spine, you're going to have a tough time coming down 2 vertebral segments below in order to get into the intervertebral interspace in the cervical spine and try to remain flat, just because of the anatomy of the cervical spine prohibits you from having a completely flat trajectory. So in this case, what I'm going to do is picture there. I'm going to have a entry point that's closer to midline, picture. And what I'm going to do is I'm going to break the skin, and what we would do here is obviously use our local anesthetic first and create a trajectory that we can use, picture there. And picture there. In this case, we're going to enter slight paramedian approach, and we're going to use loss of resistance as we have with the lumbar spine as well. Picture. And we've got ourselves positioned now in the epidural space. Now obviously, as we talked about, a few things. One, we have a distance to travel, and I have in this case chosen a 70 centimeter lead in order to make sure that once this is positioned, that we have enough room in here to tunnel to the pulse generator. As we advance and enter, you can see I've already got a trajectory that is moving towards that lateral side. So as we discussed in the lumbar spine, what I'm going to do is I'm going to turn the bevel, and I'm going to try to create a trajectory that allows me to enter slightly to the left. And you can see that first contact now is exiting more midline than it was when I was originally advancing the lead. So in this case, what I'm going to do is I'm going to do incremental advancements, and as I do those advancements, we're going to take fluoro images, and we're going to see that we have a nice trajectory that we're taking here. Now, every once in a while, you'll see that there's a movement there towards that right side, and I'll go live for a second and stop. And what I've done is I brought that contact towards the midline, and I'll advance with that picture. And you can see that that lead is now tending to move towards that left side, picture. And I'm maintaining torque on this lead so that I can advance it and stay towards that side. Now I'm going to let go of the torque because we want to sort of steer it back live. Stop. And now we've got a nice position across midline, and we've got 3 or 4 contacts already out. We're just going to go ahead and get a lateral image, and as we get that lateral image, we're going to see that we are placed nice and dorsal. Good. Okay. As you can see, we have most of those contacts exiting the epidural needle, and we are nicely nestled in that dorsal epidural space. And we don't have any threats of anterior migration at this point. We'll go ahead and bring it back. Excellent. Okay, so as you can see, at this point, we know that we have a dorsally placed lead, and what I'm going to do is move the C-arm towards the head. Picture there. Okay, and now we're going to go ahead and give me some live, and we'll sort of watch the behavior of this particular lead as I advance it, and you can see that now that we've created a nice dorsal track, I can just stay dorsal throughout this entire trajectory and remain midline and take this all the way up to the C2 segment.
So you can see your angle here is quite steep. Despite that, Dr. Navalgund was able to remain posterior, and because of the anatomy in the cervical spine, that's generally the case. Even though your angle is quite steep, you'll be able to remain dorsal.
Relative to the canal diameter, you've got a lot of cord and it occupies more of that canal diameter. So to actually drive a lead anteriorly in the cervical spine, you have to apply a fair amount of pressure to do so. So if you meet any resistance whatsoever, even at the slightest bit, you want to reposition and redirect your needle so that you have no resistance as you're advancing. If you have trouble obtaining a lateral image in the OR, just because the shoulders and things can get in the way, arms to the side is very helpful. If the arms are not to the side, then a contralateral oblique view can often be very useful in making sure that you are dorsal in the epidural space.
Yeah, and then some people will actually look at, a contralateral oblique or a lateral image even when they're doing loss of resistance. And if you're new to cervical space and cervical stimulators, you may want to do that for lead placement. Others, once they get very comfortable, it's similar to a lumbar row, they'll place the needle and then go lateral or contralateral oblique to make sure that the lead goes posterior. Just really depends on you, your comfort level, and how you feel about it.
As far as the permanent procedure, the cut down is very similar to the lumbar area. You make your cut down and your needle dives right through the incision. I have here a 50 centimeter tunneling device, which is a much longer device than the one we were using before. And as far as tunneling is concerned here, we use the same technique. After the cut down, you want to make sure you put a little bit of a bend in this tunneling tool, and then you can actually tunnel from this incision point, and you can tunnel down to the same area we were for the lumbar area over the iliac crest and place the pulse generator. A lot of times if people are not as comfortable with the distance of the tunneling, we can actually use the shorter tunneling tool in a two-step fashion in which you will make a small incision along this superficial tissue here, and then you would essentially pass the lead through, tunnel again to the next location, and then pass the lead back through as well. For the most part, I use the longer tunneling tool. It's more convenient, and it's a one-step process.
And what lead size did you use right here?
In this one, I used a 70 centimeter lead, and just to give you an example, with the 70 in this particular patient, it would be just enough to place one strain relief loop at this site of the insertion through the thoracodorsal fascia, and then one underneath the pulse generator.
And as you guys remember, just from doing cervical epidurals, in clinic, the loss is a little bit different. So if you feel like you're not getting clear loss, certainly use your fluoroscopy, go lateral, do your contralateral oblique, whatever you need to do. Use a lead blank. There are multiple opportunities if you feel like you don't have a clear loss to figure out what's going on, and use those opportunities because you are in very close proximity to the cord in this space. You're at a steep angle, so you want to be incredibly careful and do the procedure safely. Minnie D here again. For more on generator placement options, let's talk to Dr. Sean Lee.
Some people choose to put the battery in the flank. Some people choose to put the battery in the standard buttock location. The reason why I may choose the flank is there's just less distance to tunnel. That's something that often requires using a really long tunneling device, can cause discomfort for the patient. Having a longer lead makes it a little bit harder to drive that lead into the target area in the neck. So you want to use the appropriate size lead. So if you can use a 90 centimeter lead, that's fine. But if you can get away with a 70 centimeter lead, it'll be a lot easier for someone to drive that lead. For the cervical spine, it'd be probably impossible to use a 50 centimeter lead unless you're 4'2".
If you're going to place the generator in the flank, what are the special precautions that you want to take when creating the pocket?
Very good question. Anatomically, you want to make sure that there's enough space between the 12th rib and the iliac crest. Sometimes it just doesn't allow for it. Then I'll move down underneath the iliac crest. You want to avoid placing the battery at the belt site. So carefully ask the patient in the preoperative area where they will wear their belts and mark that out.
Thanks, Dr. Lee. Let's go back to wrap it all up with Dr. D and Dr. Yash Navalgund.
What kind of tips do you have, or what kind of final words would you have for our viewing audience today?
Well, I think the key is that these types of procedures are just fantastic procedures that have changed the lives of so many people. And I think that as we step back, there's not too many specialties where you can get people to come back and sit in the office and cry because of how much you've helped them. In the same vein, if you do these types of procedures for the inappropriate patient and you don't necessarily do all of the legwork and the preparation, they can result in bad outcomes. And so what I would really say as a take-home message is embrace the therapy. I think it's really a fascinating time in medicine, especially since we're moving so much more towards software and the programming capabilities of these devices, not so much the hardware. And really hone in on your skills, get enough cases under your belt, feel comfortable with it, and just really focus on choosing the right patient.
So if you're young and new to this, don't be scared.
No.
Not at all, but
No.
be careful. You know,
Yes.
do your due diligence, prepare, look at your imaging, figure out what you're going to use, know your company that you're choosing, know what kind of tools you have, know your anchoring tools, know your tunneling tools, know everything before you get in there.
Absolutely.
Do your homework, and I would even add in, get a good mentor. So you should have someone you can call. You should have phone Dr. Navalgund, in the OR. So if you're having a problem, you should be able to just say to your scrub nurse or a resident or fellow, whoever's in there, hey, we need to call, this person, and they're going to help us, and we're going to get through this. And don't be scared to ask for help. That would be, my advice to people who are just starting out doing this.
Yeah, definitely. Have a lifeline readily available. Make sure that you're comfortable talking to your mentor, and continue that. I continue to have mentors of my own that have helped me throughout my career, even for the past 15 years.
Well, thank you, Dr. Navalgund. This was just such an important segment that I know that our viewing audience is absolutely going to benefit from. We hope that you guys took away many tips and tricks that you can apply in your practice, and we will see you next time.
Thank you so much.